This meeting is recorded, or being recorded rather, um, and this will be posted to the website. Um, and sorry, I'm letting people in as I'm speaking. And you can see on the screen we have the agenda. We have first the welcome, and then we will have Jessica Dusick with the H&M work group and rack update, and then Max with the YSCHN DEPDST update, and then also updates from OHA leadership with Dave and Meg. We will have a bio break in there, and then we'll have Jill Leakey with telehealth, and then liaison and chair updates. And then we will also be having just a direct payment update with the chairs, but also the attendees will be Mercer and John Walker Barrett from OHA. As of right now, we haven't had any new movement on the new timeframes for this meeting. The reason I haven't moved forward is with the new director hopefully coming on board. If they would like to have a new time frame, I didn't want to have us moving everything around and then just in 2 months moving something else around as well. So hoping to have a new director and then having their input as well. Jessica, are you available to give your update?
Hey, Janet, this is Dana.
Yeah.
Sorry, I was going to raise my hand and then you jumped.
Oh, sorry.
No, it's fine. So I was just looking for an opportunity to mention that our August meeting is scheduled to be in person.
Oh.
It would be August 6th. And so I just wanted to kind of put it on people's radar. We can talk about it again at the end of the meeting. But just being aware that that's coming up next month. And it says virtual at the bottom of the agenda. So I just wanted to correct
Is that the one though that lines up with everybody else's? Or I thought that was the September one.
Everybody else is meeting in September, but we meet in a different week. So it doesn't
Doesn't matter.
necessarily save anybody, right, travel time, that sort of thing. But I mean, it's certainly something we can discuss in the future. We just knew that it wasn't impacting other meetings.
Oakley dokley. All right. So everybody, it's going to be a hybrid in August. And thank you, Dana, for pointing that out. And my apologies for not having that updated on the agenda at the very bottom. And then I will make sure to send that out with the meeting room for next month's schedule. Dana, is there anything else I'm missing on that?
No, thanks.
Thank you. Jessica, are you available?
Yes. Hi, Janet. And
Hello.
everybody. Hello, everybody. I'm Jessica Dushek, she, her pronouns with OHA Medicaid. And I'm going to give you all some information on the handicapping malocclusion work group and then also the dental OAR update. So with the handicapping malocclusion work group, just as a recap, we've met in May and June weekly, and participants included CCOs, dental groups, and orthodontists. And we did come up with 5 recommendations. Those I will be sending those out to the work group for one more look over, and then those will be being sent to leadership, OHA leadership, and HERC. We are hoping to have a dental director soon. Of course, we want dental director approval and such with these recommendations. So I just wanted to share with you what the recommendations are. So the first one is clarification on the benefit criteria, and that in those recommendations and clarification will be provided through HERC guideline notes in OARs and also in the fee-for-service decision tree document. The next one is allowing for additional comprehensive orthodontic treatment codes, and that would be the codes D8070 and D8090. And the recommendation is for those to be included into the risk corridor of starting in January of 2025. And the third is guidance on when D8660, the pre-orthodontic evaluation, should be used. So guidance on when the evaluation should take place and also how, so we could have a standardized process for those. The fourth is a consistent appeals process. So providing more guidance and the best recommendations for when appeals need to be made. And then the fifth is providing guidance on when members transfer care. So there are situations, of course, where members start in orthodontic care in one area of the state and then might move and not only change CCOs, DCOs, but also, of course, orthodontic. And so those are the recommendations. Any questions about that? So I'll be sending a cleaned up version to the handicapping malocclusion work group to review. Oh, I see a hand up. And is that Dana?
It's me. Yeah.
Hi.
Hi. So so you're just, first of all, I missed the first one, so I need you to repeat that. But the second thing is,
Oh, okay.
are these in writing somewhere?
Yes. Yes.
Okay. So are you
they
going
are.
to send those out to the whole group, or just to the handicapping malocclusion work group?
At this point, just to the handicapping malocclusion work group, just for
okay.
a final look over. And then yes, they can
Okay.
be shared.
And then you're bringing it back to Oral Health Forum for the whole group to see?
I don't know, maybe Nathan, are you there? Can you hop on to answer Dana's question? I'm not sure exactly on that process. Oh, awesome. Thanks,
yeah,
Nathan.
yes. Thank you, Jessica. I think the forum is pretty much done, Jessica. So I think when you do the cleaned up version and you're ready to send out to the forum, I think it can be shared out with this entire group at that time as well. And the recommendation really are those will be taken up by, some of them led by Herc and some of them led by the new incoming dental director. So turning these into any sort of action plans and changes and timelines on when some of these changes might happen, that's all still to come. But the work group was able to do some great work narrowing down on some specific actionable topics for us to work on. So, but I think we're ready, Jessica, to share them out. I think it would be fine to, once you've got it cleaned up for the forum, to also share it with the whole group here.
Awesome. Thanks for hopping on and answering.
Great. And then, so would we expect to have this on our August agenda, just kind of as an overview and make sure everybody sees it?
I think that would be fine. You will have seen it in writing, between now and then, and so as a follow-up discussion, I think that would be a fine. From my perspective, I don't set the agenda for the meeting, but from my perspective, that works for me.
Great. Thank you.
Not sure I'm loving this together mode. So I'm gonna hop off camera, and Jessica, I'm gonna let you finish talking about the
leave.
rack.
Okay. All right. So then the next item I was going to talk to you about was the rack. So we held the dental rack in June. Thank you all for those of you who were members of that and provided great suggestions and input. Because of all of the input that was provided, Napua and I, Napua led the rack. She's also a policy analyst with dental programs. So she and I held the rack, incorporated the suggestions from the group, and are having a continuation of the rack. And that meeting is on July 23rd. And later today, REC members will be receiving a revised version that incorporates the suggestions that were made in the previous recs. So we will be having that. RAC is held on July 23rd from 10 to noon. And then the effective date for revised rules will be 1/1 of 25. And also, let's see, so once we will hold the RAC on July 23rd, and then public input will be allowed until December 21st. And those of you who are RAC members, you'll be receiving a revised version later today. Any questions about that? I just want to remind everybody that, so the RAC revision is just for clarification. Benefits aren't being changed, but it's just for readability and clarification. Dana, is your hand up again, or is it still up from before?
Sorry, it's probably still up from before.
Oh, okay. But huge appreciation for those of you who provided input and who participated and were RAC members. Really appreciate that. No questions? All right, well, thank you.
Oh, you gotta love Teams and their updates. I'm learning currently how to turn it off. So my apologies for people that get to see us in together mode. Some of you may not even be able to see it. And currently it looks like I'm in a forest. Okay. All right. So our next guest is Max. Are you available, Max? One moment. Anne's here. Phenomenal. Thank you, Anne. And while we're waiting for Max, Dana did remind me that our next meeting in August is a hybrid meeting, and I'm hoping that we could have a room reserved on the bottom floor so people don't have to have visitor passes to go up the elevator or anything like that.
Okay, I'll see what's available. Most of those are taken, but let me double check.
I really
Did we
appreciate
want-
you.
Yeah, did we want to move on and wait for Max to hop on?
Yeah, I am. Oh, Max, hello.
Oh, there he is. Okay, great.
Are we ready for my presentation?
Yes, we are.
Okay, thank you, and thank you for joining slightly behind schedule. I was just finishing a different presentation. Hi everyone. I'm here to present about the young adults with special healthcare need Medicaid benefit, which comes into effect in January next year. Thank you. My name is Max Devenoncourt. I'm a doctor and a public health professional. I'm a policy analyst for Weishin within Medicaid at OHA. And I oversee implementation of this program, which is a collaborative process across different divisions, including Medicaid, health policy and analytics, and others. So thank you for welcoming me to your space. I'll move to the next one. The agenda is to do a brief overview of the Oregon 1115 waiver. I'm sure you're all familiar with it, so I won't spend too much time, but then try to answer some questions that you may have about the WISHN program, which is the acronym for Young Adults with Special Healthcare Needs. So from this point on, I'll say WISHN. I'll go over when the benefit comes into effect, why it's important to expand it to the population that is concerned, who qualifies, and what benefits are included and how this becomes relevant for folks in this forum. I'll leave some time for questions at the end. I'll move to the next slide. The next slide, please. I'll move to the next slide. Yeah, there you go. Thank you. So Oregon's 1115 waiver, you may be familiar with it. For us, what's important is the fact that OHP eligibility has been extended for certain population categories. So think young children, youth, and young adults. Young adults are the ones that I'm going to talk about today. And what's important is that OHP coverage is extended all the way up to age 26 for that age category, which includes EPSDT, health-related social needs benefit, and others, which I will go over a little bit later. I'll move to the next slide. The Oregon 1115 waiver goals obviously are to address health inequities within the state, make sure that folks have access to equitable, culturally and linguistically responsive health care, and make sure that that population, young adults with special healthcare needs, have access to health-related social needs benefits, as well as early and periodic EPSDD screening, diagnostic, and treatment, also known as EPSDD. I'll move to the next slide. All right, so who are WISHN? So WISHN comes into effect. So the Young Adults with Special Healthcare Needs benefit comes into effect on January 1st, 2025. And is a new eligibility category under Medicaid. I'll move to the next slide. So yeah, who are they? They are young adults, so think individuals between the ages of 19 and 26, and who are at risk for ongoing, think chronic health conditions that require special long-term treatment. So anywhere from physical, intellectual, or developmental disabilities, long-standing medical conditions, or any mental health condition that requires long-term treatment. So young adults, 19 to 26, who present with any of these conditions would qualify under WISHN and would get extended Oregon Health Plan benefits. I'll move to the next slide. So why is it important? Well, in Oregon, 1 in 5 children under the age of 18 have a special healthcare need. So think that they will become young adults with special healthcare needs, which is a sizable population. They're at risk for more health and health-related social service needs, and that needs to be addressed. So the waiver gives WISHN extra time to transition from what would have been their pediatric benefits to adult coverage and care. So basically, it does extend the pediatric level of coverage into young adulthood all the way up to age 26. I'll move to the next slide. So who qualifies? Well, next year, because we're doing an age-based rollout, it won't be the whole age category from 19 to 26. Only 19 and 20-year-olds will have access next year, and I'll show you another data point a little bit later on as to how we're doing that age-based rollout. Next year, individuals 19 and 20 who have certain health conditions outlined in the 4 points on the right will have access to the Wishon benefit. So the pathways are the passive pathways. So think youth who are currently on OHP who have one or more complex medical condition, have a mental health condition or substance use disorder or some kind of neurodevelopmental condition, or 3, an intellectual or developmental disability identified by ODDS, will be automatically evaluated and enrolled in Wishon if they meet the age requirement, the financial requirement, and are 19 or 20 next year. Yes, I'll take a question. I believe, Dana, if I said your name right.
Hi, thanks. Sorry, I didn't mean to interrupt, but I thought it might be good to sort of clarify when you're talking about extra benefits. Are you saying that the Wishon population is eligible for the plus benefit, the OHP plus benefit that is available for kids under 21 and pregnant women? Or are you saying that it's the EPSDT benefit that is extended?
It's both, and I will show you in a couple of slides what they get today and why we call it extended, aka what they will get starting next year. But I really appreciate your question, so I'll spend more time explaining that in a couple of slides. Thank you for pointing that out.
Okay.
Yes. For new OHP applicants, the 4th pathway is where they will be identified because we won't have pre-existing data around their coverage needs. So we identify them for having elevated service need through what is called a Wishon eligibility screener. I'll move to the next slide. So how does it work? Well, having an elevated service need, will be evaluating new OHP applicants starting on January 1st, 2025. So all folks between the ages of 17 and 20 who are applying for Medicaid through the WAN system will be prompted to answer screening questions to see if they have the qualifying conditions that I mentioned a little bit earlier. The screening survey was developed in collaboration with OHSU's Oregon Center for Children and Youth with Special Health Needs, also known as OCHN. They helped us develop a 6-question screening tool that will allow us to identify folks with elevated service need, which I believe is my next slide. So the questions are outlined here. They're the actual questions which are in the screening questionnaire and include assessments like, currently, do you take prescription medicine? Do you often use medical care, mental health, or other health services, including oral health services? Do you need assistance to do your everyday activities? Do you get treatment or counseling for mental health or substance use conditions? To use medical therapies or medical equipment or assistive devices? Any potential Wishon who answers positive to 2 out of the 6 questions will be considered Wishon and be granted this Medicaid benefit. And I will tell you what's included in that benefit a little bit later on. Thank you for this next slide. So this is the table I was talking about that has a comparison table as to what 19 to 26-year-olds get today and what they will start being eligible for starting next year. Currently, OHP is extended to folks who have an income up to 138% of the federal poverty line. They would get EPSDT, enhanced dental and vision benefits that would end at age 21, and no health-related social needs benefits, so no HRSN. Starting next year, the income bracket is increased. So additional folks who wouldn't have qualified today for Wishon get access to Wishon up to 305% of the federal poverty level. They get EPSDT, enhanced vision and dental benefits all the way up to age 26. And they also get HRSN services covered. We're mandated to evaluate them for their HRSN benefits every year. So that's a big shift and a big difference. I'll move to the next one. We're doing an age-based rollout, and I described it a little bit earlier. You'll see that in 2025, only 19 and 20-year-olds will qualify, but every year thereafter, all the way up to 2030, we increase the age bracket of those eligible. So 2026, 19 to 21, so on and so forth, until all of the 19 to 26-year-olds within Oregon will be eligible by 2030. Yeah, I'll move to the next one. I was just pausing to see if there was any questions. EPSDT, which currently ends at age 21 for those in that age category. EPSDT coverage will extend all the way up to their 26th birthday. Once someone is enrolled as Waishin. I'll move to the next one. And then they also get HSN benefits, which provide housing support, nutrition support, and climate support. And they're evaluated every year to make sure that they meet the qualifications to get those HSN benefits. I'll move to the next one. So this is our estimate of who will be considered Waishin starting next year, 19 and 20-year-olds. So we have up to 6,000 new OHP applicants who will be evaluated and potentially deemed Waishin. Our newest estimates have increased numbers, so it's probably way more than 6,000 at this point. And then current OHP members who will see their benefits extended, it's north of 16,000, which brings a total of more than 22,000 folks who will be considered Waishin next year and will have access to, like I mentioned, OHP Plus, EPSDT, extended dental and vision, as well as HRSN coverage all the way up to age 26. I'll move to the next one. Yeah, so for the Oral Health Forum, I'm not really sure what sort of information you need, but feel free to ask questions if you need additional information or additional resources. Feel free to get in touch with me. I have to let you know that we're currently in the process of rulemaking, and Waishin rules will be going live January 1st as the program comes into implementation. So yeah, opening it up to your questions or any other ways in which this information is relevant within the Oral Health Forum. Yep, I have a hand. Dana?
Hi, this is Dana again. So one of the questions that has come up around this program in the tech work group is how we identify who these individuals are. And so has there been a solution to that? How do we know who these kids are?
Yeah, so I'm doing a lot of community engagement with a couple of different key partners within the state. So I've been meeting a lot with CCOs to make sure that they know that this benefit comes into effect and that they have the infrastructure to implement it, as well as refer potential Waishin so that they apply if they need to, or that they make sure that they have gotten the summary of their enrollment within Waishin. On the fee-for-service side, there's a lot of engagement needed with providers. So I guess a request to you is if you have information about provider networks, feel free to send that to me, because then I can schedule to attend those forums and share this information and make sure that they start thinking about the infrastructure needed to implement Waishin. So it's a little bit of give and take. The plan is to reach out to providers but connecting us to the right network is sort of the challenge that our team and myself personally are facing. If you have an information around like dental providers and you know who might appreciate this information, please let me know, and I welcome that information. Any other question? I have Jennifer. Yeah.
How often will they be evaluated to see if they still meet the criteria?
Oh, that's a great question. So continuous eligibility. So anybody who's deemed WISHIN will keep their coverage for 2 years. That's their continuous eligibility period. And then every 2 years, they get a summary of their coverage, requesting them to confirm that they still meet the qualifications. So they likely will keep their coverage all the way up to age 26, but instead of having folks reapply, we really just send them a summary of their coverage and say, hey, has anything changed? Once folks attest to their situation remaining the same, they keep their coverage in 2-year increments until they age out. So in that way, we really make it easy for members to keep their coverage and not have to stress out about aging out or not meeting the qualifications. As long as they met it once, they keep that coverage for 2 years.
Thank you.
Any other questions? Gary.
Yes, thank you. You alluded to communicating to you and I guess your team on providers that might benefit from this information in this presentation. Certainly the DCOs, dental care organizations, can assist with that. I'm assuming we'll get a copy of these slides and, it would be standard in our own communication with our provider networks to pass this along. But we'd appreciate just a copy of the slides so we're consistent with the information that you're presenting.
Awesome. And I will do you one better. I will send a copy of the slides, but I will also share. We have a 2-pager that sort of lists the main points that I just talked about today, as well as a web page, which is, again, preliminary information as to what is WISHIN, why it's important, and how folks should be thinking about implementing it. I think these 3 resources would be great starter points for providers and provider networks for thinking about ways in which to include this information for their community members and end users. Yep, I'll let folks take it over.
No, you're doing phenomenal. I just want to let you know, if you provide me that 2-pager, I'm happy to get it out to everybody when I do the quick synopsis of this meeting. And then also, it is in the chat, but the slides that you provided is on the invite as well. So just letting everybody know verbally as well.
Awesome.
Are there any other?
Thank you.
Oh, no, thank you. Beautiful presentation. Are there any other questions for our guests?
Janet, I have a comment. The slides are also posted on our site.
Perfect. We are on this. Yay for 9:40 on a Tuesday.
Awesome. I know this is my time. I'm not sure if folks have last minute questions. Feel free to ask away. I won't take too much more of your time, but thank you for having me in this space and happy to share this information. Thank you.
Thank you very much for all your time. Have a great day.
Thank you.
Mr. Inbody.
Hello.
Hello.
I get to join you sitting on the rock.
I love it. I love it. Oh, you see it then. Okay, good. It's not just me. I know some people don't see the team together mode.
Yeah, I
It's
know what to make of that.
it's you go to gallery and it will change your view. Uh, so Mr. Enbody, can you please give us an update from the OHA leadership and anything phenomenal happening?
Well, probably the big news this week is the launch of the bridge plan. More than 2 years in the works. It launched on July 1st. Very exciting. We saw on the first day about 23,000 people immediately gaining access. So that was exciting with very few hiccups. Obviously, we're scouring to make sure that the people who are gaining access are the ones that qualify, and those who should be but aren't, that we include them as well. Just as a clarification, this program is for those who that don't qualify for Medicaid due to their income. So those that make 138% to 200% of the federal poverty level would qualify for this program. And part of this, and our expectation anyway, is as we go through the redetermination process for Medicaid, that individuals who no longer qualified for Medicaid, this would be a potential alternative so that they can maintain their health care. And just something to be proud of as Oregonians. We are consistently identified as one of the top states in terms of individuals retaining their healthcare coverage. Last I saw, we were third or first, depending on who you ask, but doing very well in terms of ensuring that people have their healthcare coverage. So it's very exciting. I think there are just a lot of people that got this to the finish line here and were able to get this launched. So very exciting. And I'll be able to give you more information as we learn more about who the individuals are and what to expect in terms of maybe differences or different needs for this population if there are some variances in terms of who they are. Another note about this, I think you may be aware of it, but just to make note of it, the services through the bridge plan are only available through CCOs. So unlike Medicaid, which also has an open card option for CCOs, for the bridge plan, it's only through CCOs. The other big news for us, or the primary focus of our attention, has been around the CCO contracting. We're in the process of going through the 2025 contract restatement process, which is the review of the current contract with the CCOs, making changes and improvements or corrections to the existing contract to be in place for 2025. We've sent out the draft version of that contract to CCOs. They're currently reviewing it, and they'll be providing their feedback in the next week, at which time we'll make modifications to the existing contract. I know I won't spoil the excitement later in the meeting. I think John Walker's going to be here to talk to you about the dental directed payment, but that's one of those considerations for the changes within the contract. We had a number of significant contract changes, and so those would be accounted for within this new contract restatement. Also, I had mentioned the bridge plan. That will be a new contract with CCOs, as well as what we refer to as the non-Medicaid contract, which is a contract with the CCOs that we have for services that are state funded, which is primarily the Help Your Oregon program, but not exclusively. And so all three of those contracts would be reviewed and revised through the restatement process. The other thing that we're doing this year as a result of the waiver is we're also going to be providing an amendment to the existing contract. The housing component of the waiver is scheduled to roll out on November 1st. And so we'll be doing an amendment to account for those revisions. And that amendment is being sent to CCOs in about a week. as well as more detailed language about the specific changes to the next year's contract as a result of the waiver, and that would include many of the WISHN changes that Max had just presented to you, as well as the nutrition services. The other thing that is just getting underway is we're preparing for the next CCO contract procurement process. Our expectation is that we'll officially kick off that work in August. So probably at next month's meeting, I'll be able to give you more details about what that looks like. Generally, what we're doing now is we've had a number of meetings with the governor's office to get a sense of what their expectations are for this next go round in terms of the procurement process. This is a contract, although we're starting now, the new contract would not officially launch until January 1st of 2027. But obviously there's a long lead up to that time where we have to go through a full procurement process, as well as the development of the new contract, and then obviously ensuring that the CCOs have an understanding of what the expectations are for the next contract. I note that here because one key component of this work, this procurement process, is the community and partner engagement portion of that work. And obviously there will be an interest in learning more about what we would like to see in terms of oral health considerations through the procurement process and in the next contract. So I'll definitely be looking for this group to assist with that component of that procurement process. But like I said, I should be able to give you more information about the details of that work next month. With that, I will see if Meg's with us and if she has an update for us on the dental director. You get to join me here on the Rock.
Hello, it's lovely to be on the Rock with you. Good morning, good July to everyone. And thank you so much, Dave, for sharing that update about the launching of the Bridge program. It is really so very exciting. I do have an update about the dental director. We are in the very final stages of recruitment. So we have completed, as many of you know, again, a huge thank you to those of you from the Oral Health Forum who made time to join the Direct Care and System Partner panel. We really appreciated your thoughtfulness, your reflection, your consideration, and your contribution to this recruitment. We have completed our other internal panel interviews and are now holding conversations with 2 final candidates with our Medicaid leadership team to discuss goodness of fit and interest in the job, as well as what we can do as an agency to support the dental director to thrive, to be here for the long haul. We have heard loud and clear from you all the importance of really emphasizing the need to stick through what will be a lively onboarding. We know that this position obviously has not been filled and that there's a lot of work to do, a lot of really exciting work to do. And so we just want to make sure that we are transparent and really thinking together with the candidates about what we as an agency can do to ensure that they are well supported in this position. Those conversations are happening next week due to summertime scheduling with our candidates. And so this is getting pushed back a little bit farther than we had hoped, but really wanted to take the time that we needed to make sure that that we are making an offer to the candidate that's the best fit, both for them and for us. And so have decided to really use the time. This has obviously been a long incoming recruitment, and a couple of extra days I think will pay dividends in the end.
Are there any questions for Dr. Meg or Dave? Well, thank you to you both for being here and taking the time to be part of our forum. We appreciate you. Bye.
Thank you all.
Because we are ahead of schedule a little bit, I'm going to have Dana give a liaison update and pop on and share a little bit about the happenings with what
Yeah,
she
I
supports.
just have a couple updates on some of the work groups, and if any of the other liaisons want to share anything from their meetings, we do have a little bit of time. So the first thing I wanted to mention is that the MEOC meeting, which is the Member Engagement and Outreach Committee, is going through a little bit of a reorganization. David Ballantyne, who was the OHA staff person who um, ran that meeting, has moved on to another position. And so the MEOC has been sort of taken over by one of the new quality assurance divisions. And this is the CCO engagement division. And Sarah Miller is the manager for that. And so she is going to be sending out, we'll be continuing to have the MEOC at the same time. But we will start to see new staff running that meeting and some updates to the agenda over the next couple of months while they get their new processes figured out. And they also meet on a quarterly basis in person in Salem, but they meet on a different month than this group does. And so September is when MEOC and the tech work group are scheduled to have their next in-person meeting in Salem. And so more information, of course, will be coming out with that as well, but it's a good day to, meet your peers and the other organizations that do this work and, kind of learn from them and make some connections. It's always nice to have a phone a friend in place. So those are good places to do that. So I just wanted to mention those two things. The other thing I was going to mention about the tech work group is they are talking about this new WISHN population and how to identify them either through a PERT code or a group code. I think there's a lot of advocacy from the CCOs to make that a group code. It's much easier to track those in our system. And so if you have questions about that or concerns about what that's going to look like, please attend that tech work group or send someone to attend it. It's open to all comers. You don't have to be a CCO. And that's also true for the MEOC. So just wanted to put those two things out there. And Anne says, yeah, thank you. Tech and MEOC are the same cadence hybrid meeting as September 18th. Thank you, Anne. So do any of the other work group liaisons have anything they want to share about their meetings?
Looks like Gary has a comment or a question.
Yeah, just a very quick update on the myself as the liaison to the Oral Health Advisory Panel to HERC and to HERC. The OHAP, I had reported our last meeting, the OHAP met May 29th and made some recommendations for changes to the frenectomy guideline, tongue tie guideline. And that is now on the agenda for the value-based benefit subcommittee and HERC meeting on August 8th, which I'm assuming they will approve. Certainly have not heard any concerns about the changes to that guideline. And then also on the agenda for 8/8/24 HERC meeting is the teledentistry changes that had been recommended by the Oregon Health Leadership Council. That also was a discussion item at the OHAP. So I'm sure many of you have already seen that and don't anticipate any concerns about that either. So that's my update.
Thanks, Dr. Allen. Also, just noting we'll be getting an update on the telehealth guidelines after the break. And then Dr. Chaudhry.
So I think a few other people had raised their hands after Dr. Allen, probably in commentary of what he raised. So maybe I'll I'll parlay for those to respond, and then I'll provide an update on the other committees as well. Would that work?
All right. It's fine with me. If it's fine with Laura, she's the only one with her hand up.
Oh, my mistake. I can't see it on my phone. Laura, would you like to go next?
No, you go ahead.
Okay, great. So, two different updates. High Talk. We advanced the the 5-year strategic plan. At the last meeting, we kicked off the advancement of HIE throughout the systems of care. HIE is Health Information Exchange. No significant updates on what was shared or discussed, but wanted to share that kind of where we are with that. For metrics and scoring, the meeting that we had, there was approval of the dental preventive service for the 1 to 5-year-old measure as considered as part of an upstream measure. And there still is active discussion on the inclusion of either including a CMS pediatric oral health measure or not including a CMS pediatric oral health measure. And then there is also discussion on the adult OED measure as well. And so we hope to finalize the draft. Sorry, finalize is a bad word, but we hope to have the initial draft measures at the next meeting. And the work plan may change in terms of how quickly we're going to seek finalization, which may include finalization of the 25 measure set directly in July itself without any opportunity for additional public comment with the challenge pool, or it could be extended into August. That's still being discussed right now internally within the metrics and scoring OHA staff. Finally, I did join the Behavioral Health Committee as well in regards to the metrics and scoring committee. And we met for the first time in the last year and a half. And it was more of an introductory, get to know each other kind of meeting. But it was pretty cool, kind of being the only oral health representative and also being present largely because I serve as co-chair of metrics or vice chair of metrics and scoring. And they have a position for that on the committee. And that's how I was placed into the role. I just wanted to share that for the good of the order. And I'm open to answering any questions about it. And sorry, my voice is off. I'm kind of recovering on the mend from being under the weather the last few days.
Thanks, Dr. Chaudhry. That was good. Any questions from anybody or any other updates? We've got a couple
Dana,
minutes
it's Laura.
before we were. Oh, yeah.
I just wanted to share that the Healthcare Workforce Committee will be meeting next week on Wednesday, and we're going to be talking about some changes that have been happening with the rural and urban designations. Bob Dumig from the Office of Rural Health will be at the meeting to address some concerns that we've had because grants passed. The designation has changed from rural to urban, which affects some of the provider incentive and loan repayment programs. And that designation changed because they were 4 people over the limit, 40 or 100. But that's how little it was that changed that designation. So it won't affect the rural medical tax credit for this year, but if we don't get it reversed, which I'm not sure how we're going to do that, hopefully Bob can help us with that. It's going to affect places like Cave Junction, Selma, Agnes, and if any of you have been to any of those places, you know that they are not urban. So once again, that meeting is next week. Starts at 9. If anybody needs more information, just let me know.
Great. Thanks, Laura. Any others in the last minute before we take a break? All right. Janet, I think we're ready to take 5.
Perfect. See you guys back here at 10:05 for our next presenter. Welcome back, everybody. It's 10:05. Jill, are you available? Are you here?
I am. Hello.
Hello, how are you?
I'm good. How are you?
I'm well, thank you. Are you ready to start your presentation?
Yeah, let me share my screen, make sure you guys can see it.
Perfect. I'm going to hop off camera for bandwidth purposes, and I'll let you take it away. Thank you, Jill. Welcome.
Thank you. Let me fix my screens. Okay, perfect. Hi, everybody. I'm Jill Lake. I'm Director of Clinical Strategies with Oregon Health Leadership Council. Today, I'm going to share with you some clinical best practices in telehealth, a guidance document that hopefully some of you have seen, but just kind of go over at a high level how we created it, the recommendations, and kind of where we hope to go from here. If you have any questions or anything as I go, just raise your hand or interrupt me. Happy to take questions as we move along. So for the agenda, I think we only have 10-15 minutes, so I'm going to give a quick overview of who we are at Oregon Health Leadership Council, our best practice committee, and the telehealth work group that created our telehealth guidance documents, how we developed them, some key takeaways, and then we'll have some time hopefully for discussion at the end. So first of all, who are we? I think Oregon Health Leadership Council in the past hasn't done a lot of work in the dental and oral health space, and so we might be new to some of you. We are a collaborative organization of healthcare leaders across the industry, including providers, payers, and professional organizations. So we're a nonprofit membership organization, and what's really unique about us, I think, is that we set a neutral table where payers and providers and professional associations kind of all come together from across the state to do projects and initiatives that are difficult for one industry or organization to do on their own. This is a list of who our members are, just to kind of give you an idea of who sits on our board and our council. So all of the major systems, as well as payers, including CCOs and commercial payers. And then we also have the Oregon Medical Association, the Hospital Association, and the Primary Care Association, who represents our FQHCs. We have three primary pillars of our work: reducing healthcare costs, fostering a thriving workforce, and promoting whole person care. I live most of my life in the promoting whole person care arena, and that's where this telehealth work came from. We have three sort of primary initiatives under that whole person care bucket. We do a lot of health IT work, adoption and spread of health IT platforms across the state. So that's where we do HIT Commons and Connect Oregon. Best Practice Committee is a committee of clinical leadership across the state. So this is like chief medical officers, medical directors from systems and plans that kind of all sit together and do adoption and spread of best practice, clinical best practice. And they create work groups underneath them, just really based on the need and what they think is important. And one of those work groups has been, up until very recently, our telehealth work group, which was formed in 2020 by our best practice committee. And this, of course, kind of sprang right after COVID started, and telehealth was being used much more than it had in the past. And there was a lot of payment open up, benefits opened up for telehealth while we were in lockdown. And we started to get a lot of questions from our providers, really more on the clinical best practice side. So now that we can, bill for this service, and now that everyone's using it, it wasn't really a question of can we do this, but when should we be doing this? So how do we make sure that we're preserving quality and safety and all of those things when we do telehealth? And there's so much gray area, especially in, early 2020 around, okay, well, I can do this, but let's say I've seen a patient 2-3 times for via telehealth. When do I need to get them back in? What if they have, this condition? When do I need to make sure that they're on video versus a telephone? So there was just like all sorts of questions. And so that's where this work group really came from in the beginning. And our charge was to identify, communicate, and support implementation of clinical best practice use of telehealth by determining and recommending the services most appropriate using evidence-based literature and expert opinion. So the expert opinion piece is really important with telehealth, because while there is a ton of ever-growing literature around telehealth, it's new enough in certain areas that we really have to rely on our experts, and that's really what our telehealth work group is. For out of scope things for this work group, we did not touch like technology platforms, payment parity, things like that. It really was focused on how can we help providers understand when they should and shouldn't be using telehealth, and if they do, kind of what is the best platform for that patient. So we've actually done 4 iterations of these telehealth recommendation guidelines, starting in 2021 with adult primary care, and then we did pediatric primary care, and then we did behavioral health. And then our 4th and final was our dental telehealth recommendations, which hopefully you guys have seen. That was released, I think, in April. We sent it out to everybody. So I'm going to stop there and see if you guys have any questions before I go into kind of at a high level what's included. I think I can see everybody. All right.
Yeah, I don't see any questions, Jill.
Okay, thank you, Dana. So this is our telehealth work group members. I think a handful of you are on here, so thank you so much for all the work you did on these. We had some really great representation from across the state of dental professionals. So the goals really for these recommendations, and they were quite a bit different. Doing dental telehealth was a change for sure from primary health and primary care and behavioral health. But what they're really meant to do is serve as a foundation for dental health providers that want to build or refine their own practice standards. So it's in no way meant to be regulatory or, setting any sort of like standards. What we really want is for providers who are either starting to do telehealth or wanting to optimize their telehealth in their practice, understand, the best ways to do that, help them start to create protocols and workflows and things like that within their own organizations. We also wanted to make sure that we were trying to promote alignment of best practice across Oregon. People are doing a lot of different things, so it's helpful to try to get people on somewhat the same page. Really highlight the importance of equity and access in the use of telehealth. This comes up over and over again, making sure that it's really clear that while it may not always be the best thing, the right thing for the patient, in a lot of circumstances, it really can help promote equity and get access to patients who wouldn't normally have access. And then also just supporting the continued growth and benefit coverage of safe and effective telehealth services. So we had all this expansion of telehealth services and benefits, and there's always conversation of whether or not those are going to go away and things like that on a federal level or a state level. And so really showing the benefits of continuing to provide telehealth services across the healthcare continuum is kind of a goal, kind of the lower goal of these guidance documents. So as far as developing them, it took us, I think, about a year or maybe more. We did a lot of back and forth, which is great to get you guys what we thought was a really helpful, valuable document. So we got together, decided what we thought should be in the document, the subsections, like they were quite different, like I said, from the physical health documents and the behavioral health documents that we did. So what would be valuable to providers? What kind of questions do dental providers have when talking about telehealth? So then we went and collected a bunch of research. I would put into the document. We would bring it back at our monthly meetings. Everyone would provide input, and we would do a million edits. And then we just did this circle about 100 times until we came up with our final draft. And then as far as the key takeaways from our recommendations, there's a lot in the recommendations document. I just realized I didn't put a link in these slides, so I will put it in the chat as soon as I'm done so you guys can see it. It's on our website. But there's a lot in there, so I just kind of wanted to go through kind of the key takeaways from some of these sections, but there's overviews, there's general recommendations, there's service-specific recommendations, and then there's recommendations around actually implementing telehealth in your practice. So key takeaways really is similar to our goals that we advocate for the continued use of telehealth as an effective platform to deliver high-quality dental health care, that telehealth facilitates improved access, but we also recognize, and it's important for recognition kind of across the healthcare continuum, that there are still inequities in accessing care for telehealth. So some patients don't have smartphones, Wi-Fi capabilities, those kinds of things that we need to continue to ensure patients have access to, so they even have access to telehealth. For the overview section, we talked about there's just kind of definitions of different types of dental telehealth. There's synchronous and asynchronous. So, and this is quite different in dental again than our other documents. Synchronous really is talking about where the connection between the patient and the provider, so whether or not that's in real time or not. And then both asynchronous and synchronous visits can be direct to patient or can be facilitated direct to patient, meaning that that's the communication is directly from the provider to the patient, whether that's store and forward or in real time. And facilitated is with the support of a dental professional, so an expanded practice dental hygienist or someone like that with the patient, with the provider offsite. And then another thing we thought was really important to call out for dental telehealth is thinking about not just being in a offsite clinic or a patient home, but thinking about all sorts of different locations where a patient might be that could benefit from dental telehealth, things like carceral settings, long-term care facilities, inpatient settings, things like that, where patients don't have access usually to dental care. Key benefits, again, improving access, the ability to provide high quality care because you will be able to hopefully get patients seen quicker, get consultations faster, identify complications earlier, so that the patients get the right care at the right time. Expanding practice efficiencies. Most data says that it reduces visit times actually in telehealth. There can be, especially when you're setting up telehealth, that whole back end administrative burden and technical difficulties to think about. But once it's dialed, in general, it's quicker. And we do see increased patient and provider satisfaction with the options of telehealth. Providers seem to like it in general. Patients, it provides them a lot of comfort. We heard from literature and just from work group members that sometimes if patients are anxious about coming in, doing kind of their first part of their exam and the history taking and the screening over telehealth before they come in can kind of help ease that transition into the clinic. And then as far as general telehealth recommendations, these I boiled down pretty far from what's in the documentation, but kind of the four main themes are: one, that no population is inherently appropriate or inappropriate for telehealth. So You can't just say, oh, new patients should always be seen in clinic or pediatric patients. Really, what's important is that providers weigh the individual patient situation, their preference, their history, and whatever services that that's the patient needs. Remote visits are most valuable for those with limited access to in-person care. So for dental care in particular, like this is very different than when we talked about behavioral health, and the vast majority of patients were appropriate for telehealth in that capacity. For dental care, in-person visits are generally preferred for anything that involves close visual assessment. But if access is an issue, then telehealth can be incredibly helpful and can still provide really high quality care. There are certain visits that can't necessarily be done direct to patient, that they really need a facilitator, dental professional support, and we list in the guidance documents kind of bullet point by bullet point when that's necessary. And then sometimes, again, especially with dental, in-person visits are necessary. When the patient needs a hands-on assessment or treatment by provider, if it's an emergency. Patient choice comes into this as well as provider choice. So an in-person choice should always be available for patients who request that. And then if it's required by insurance or something like that. And then we kind of drilled down from sort of more high level general recommendations to service specific. And this is just an example, a screenshot of what's in the guidance document, but just kind of showing you, we broke it down into each type of service, what's recommended, pieces of those services or types of those services that can be done via telehealth, what type of visit should be done. So if it's synchronous versus asynchronous, video versus pictures, that kind of thing. And then things to consider when you're scheduling that type of service for a patient. So these tables hopefully will be helpful when you're developing things like triage protocols, when patients are scheduling, to help staff understand whether or not a patient can or should be scheduled for telehealth. And then there's references, so all of the literature that we collected that supports the recommendations that we made. So just on a really high level, I took all of those and again boiled them down into what we kind of saw for each section of services. So the biggest thing is that services delivered remotely should be consistent with how they would be delivered in person. That's an ADA guidance statement. So for consultations and referrals, telehealth can be used for provider to provider consultations, really valuable for those to get providers to get talking to one another. As well as provider to patient specialty consultations. So if a patient needs to see an orthodontist just for a consult, it's recommended, but doesn't necessarily need a full exam, those kinds of consultations, pre-surgical consultations, things like that, depending on the patient, can be done via telehealth. Telehealth is great for some preventative things like patient education, oral health promotion, even fluoride varnish that we know can be done via telehealth if there's a video of it. There are certain screenings and oral exams, minor complaints. There's a lot of literature around using telehealth, especially high quality photos to screen and diagnose oral lesions and dental caries. And then also it can be used for things like post-surgical monitoring, disease monitoring, and developmental monitoring, just to see how people are progressing. You don't necessarily need to bring them in depending on their condition, or you can have a facilitated visit where a patient maybe can go somewhere closer to their house and doesn't need a provider right there looking at them, I think. And then the last section is our quality measures. So this is where we came up with the codes that I think Dr. Allen referenced earlier of what kind of codes should be used for telehealth. We the guidance documents are payer agnostic, so they're not Medicaid focused necessarily, but what we heard from our group is that having a little bit of guidance around quality measures would be helpful because there's always a lot of questions around those and like how do you use telehealth to meet quality measures, but also at the same time making sure that you're not just checking a box, but meeting the intent of the metric and getting the patient still the same level of quality care. And so we did recommendations for 4 different quality measures, assessments for children in DHS custody. So this one, we recommended that if needed, you could use telehealth to meet the metric because there's a really tight time constraint, but that ultimately it's recommended that you still see the child in person. For oral evaluations for adults with diabetes, this one ideally should include a physical exam, so it could be done via facilitated telehealth or in person, but it was not recommended to do to meet this metric through telehealth direct to patient. And then for both the preventative dental and oral health services for children and the ED follow-up, there is a lot of different codes that can meet those measures. And so what we did was pull out codes that we thought were most amenable to telehealth to meet those measures. But again, providers should use their judgment on that one because some of the codes that can be used to meet those measures probably should not be done via telehealth because of the physical exam component. I know I went through that really fast, but we didn't have a ton of time. So I will stop there, see if you guys have any questions or if anybody that was on the work group wants to add anything, because I know some of you are here.
Thanks, Jill. This is Dana. Just if anyone's thinking of their questions, I'll just chime in really quickly. That I did a laughing emoji when you said, we did that circle about 100 times because, I do feel like we went around and around, but it was so good because, we would come back and go, that's right. We would kind of confirm things and stuff. And I just want to call it to the group. I really appreciate how thoughtful this process was and that it wasn't just slapping the word dental on something that was already made for a medical thing, which happens so often. The group and Jill did a tremendous job of really digging in and looking at this from a dental lens and getting those recommendations right for the type of providers we were talking about. So anyway, just wanted to share my appreciation for that.
Thanks, Dana.
Jill, just want to say very comprehensive. Thank you very much. Really appreciate it, and also appreciate the time to grind through everything. And then finally, I also, Janet, I think Samantha's in the lobby. If you can let her in as well, that'd be great.
Oh yeah, I let her in.
Okay, great. Thank you. Thank you again, Jill.
Thanks, Manu. All right, so I put the link to the recommendations in the chat. And then if you guys have any questions about it or anything like that, please let me know. I can put my email in the chat as well. But thanks so much for having me.
Thank you, Jill. Okay, I think we are ready then for our next topic. So this is the direct payment discussion. And I think we wanted to just sort of tee up a little bit about, where we are in the process.
35.
What's that? So we're getting some background noise, so we'll see if we can get somebody muted here. But wanted to just let folks know. So there was a group of folks working with Chelsea to come up with some draft ideas.
Where
we're getting some background noise, so if you're not on mute, can you please check your phones? Thanks. So just wanted to level set and let folks know that there have been some conversations with Chelsea. Unfortunately, she wasn't able to be here today, but we wanted to provide some time for discussion And we have folks from OHA and Mercer to also provide some information on it for our discussion. So I am wondering if Dr. Franzen, are you available to sort of kick off a summary of what was submitted for the direct payment discussion from your perspective?
Sure, I can just talk briefly. There was some input requested on how we might think about coding, what to include if a preventive or minimally invasive bundle was to be considered. And so through a collaborative process, we put together several different options and submitted that back as input. And I believe we're going to hear maybe some of the progress that OHA and Mercer have made on that today. I have not been involved in the other options around payment for volume and those pieces. So hopefully we'll be able to hear on both of those elements. So I wonder if we should have John share where they're at and we could go from there.
Great, thanks. So, Mr. Walker, does that sound like a good plan?
That sounds good. So I think we can move to the next slide here. So based on our feedback after our previous meeting, where we shared some directed payment ideas, we tried to narrow that down to the ones which seemed most interesting or acceptable or least problematic to the different shareholders involved. And so the ideas that we're currently thinking for a directed payment are some type of unique user payment, some type of follow-up visit payment bonus, a bonus for new providers, a bonus for the first set number of Medicaid visits in a quarter a year. This is to address the fact that a lot of dentists, we're talking about the administrative burden of getting signed up for Medicaid. So if they are kind of provided a bonus after taking a set volume of Medicaid patients, that's kind of a payment to deal with that administrative extra hurdles they're facing there. And then the final idea was a preventive minimally invasive bundle, which Dr. Franzen was talking about earlier. So these are the ideas we're currently looking at. Mercer is in the process of pricing these ideas and try to operationalize them a bit to give us a sense of their viability and their potential costs. And if the amount of money we currently are dealing with would be enough to make a difference to be worth the effort. So that's currently where we're standing. And then I think if we move to the next slide, we have Mercer, we have Adam, and I believe Emery from Mercer on here. So they looked at the back and forth about what a preventive and minimally invasive bundle design could be. And we're looking at two really. One is a pediatric preventive bundle, then increased payment for a completion of dental cleaning, fluoride, and sealant. And then a minimally invasive dental bundle. And this would require a cleaning service, as well as 2 or more of the additional codes within a sort of 6-month period. So it'd sort of basically be some combination of these codes would result in that bundled payment bonus. I don't know if Adam, you would like to talk about this a little bit more?
Yeah, I can. So I think this was, and I know Dr. Franzen had provided this information. So thanks to her, and then any other dental folks that may be on the phone that collaborated with her on that. But so we're in the process right now, just identifying in the data from a year of data, I guess the number of bundles that exist right now. So I think there'll be some discussion with the state as well once we kind of figure out sort of baseline of what we would expect. And then also we'll have to price things, I guess, to figure out, what that payment might look like. I expect, and John, I think we talked with Chelsea a little bit on this too, that I think there'll be different incentives that are assigned to each of these. So I know there's a little bit more of a push for the second, which would be more of like an adult bundle.
Yeah.
So still will be some increase on the pediatric bundle, but I think probably in most cases that bundle sometimes is just a single visit anyway, so it wouldn't require that kind of longer time period anyway. But so we'll be working with the state just on modeling what those scenarios might look like of different I guess different magnitude of what those incentives would be between these two bundles. So
Yeah, and if on the previous slide we showed the current options being considered, we will probably look at more. It's possible that the directed payment we put together, the prepayment we put together, will contain more than one of those options. So it could potentially be a combination of 2 or 3 of those options. As we sort of stated before, the goals are to get more dentists that are taking Medicaid patients, and to get more utilization, particularly of the adult population, which has not rebounded from COVID in the way the pediatric population has. So those are 2 main goals, and it might require more than one directed payment and more than one of those options to be combined together to try to achieve them, and to see what would fit within the budget and the amount of money we have. So that is where we currently are. We are still collecting feedback from the different stakeholders and providers and people involved. We are still open to more feedback and thoughts from this group.
I don't know, John, it looks like maybe you're talking, but I think you're still on mute.
Oh, no, I shouldn't be on mute.
Oh, so I just wanted to
Can you hear me?
see if anyone had any feedback or questions that they wanted to. Matt?
Thank you. No, I appreciate the presentation. So, John, just to make sure at least my brain is processing this right, what is still ongoing with this is specifically to these 2 scenarios here, the pediatric prevention, the minimally invasive. What is still ongoing is looking at kind of the frequency or magnitude at which these bundles would have occurred on like a 12-month look back, to sort of see how that volume shakes out against the potential dollars that are available to help determine what degree of an incentive would this be or not be. Is that an accurate way to generally understand it?
Yes, we are. So what Mercer is doing is we have the options we're considering, and these are part of that last option. And yeah, we are looking at sort of basically how much a circumstance like this does occur, to give us a sense of how much it would cost if we were to make a bundle, and obviously making the assumptions of this bonus would presumably result in more, by some, percentage more, to give us an idea of the overall cost and the viability of pursuing that as an option, both whether it would cost too much or if the bonus would be so minimal as to not be worth the administrative hassle involved. So that is sort of the main process we're going through right now. Not just with these, but with sort of all the options. How much would it cost to have some kind of bonus for new providers who sign up to the program, and would it be enough to be worth the effort and everything? So yeah, that's currently where we're standing.
Okay, no, that's helpful. And sort of building on that, then really the option 2 here, acknowledging there's other options and more work ongoing, but option 2 here would really be for adults. So if that's accurate, then it would would answer the rhetorical question that I at least had as to, could the same individual, essentially a kid, be eligible for option 1 pediatric and 2 minimally invasive. But I think what the intent is that minimally invasive would really be an adult focused denominator, if you will.
Yes, that would,
Okay.
Yeah, it's very much to deal with the fact that the adult population is not receiving the level of treatment they were back in 2019 to a noticeable degree.
That makes sense. And then the last thing, and this, I don't expect an answer to this now, but I think as your guys' work unfolds and we interface with more report outs on what you're working on or what the results of the modeling show, I'd be interested to see, hear from Chelsea, hear from Mercer or you about any implications, whether it's a constraint or an opportunity attributable to the Medicaid and CHIP managed care access, finance, and quality rule, which had a fair amount of July and then after changing regulations for rate setting specifically attributed to state directed payments. So not making any inferences now on implications, good or bad. I think it's too premature to do it, but I'd be interested to see or hear a context understanding as this work unfolds as to any roadblocks, any barriers, or any enabling factors that may have been afforded in that recent final rule that produced the addendum to the rate setting guide.
It's a good note.
Dr. Franzen?
Oh, I see a couple other folks have raised their hands, so I'm happy to defer time to them. I more just am curious as we get to the end of this conversation to identify what we're projecting as timelines. Is the August meeting going to have a presentation on this? Is the next step in a different forum? I just know from Chelsea that there are some time pressures. And so I'm curious about timeline. And then are there other venues beyond this meeting where this information is planned to be presented? So, but for others that may have content comments, I would defer to them first.
Dr. Manu?
Thank you. Just one comment that I want to make. Mr. Walker, you've indicated that the two primary objectives are to increase adult utilization and bring on new providers. The fundamental reality that was shared a few months ago at a committee meeting by the Oregon Health Authority was that 12% of the Medicaid dental providers in the state perform most of the Medicaid care for 34% of Oregonians. And so the question that I have, not question, but rather the request for consideration as deliberation continues internally, is that while there is greater investments to bring on board new providers with continuing decreases in rates for the already existing system, I'm fearful that in a year's time, we'll be at net zero in number of providers that are taking Medicaid. And so please take that into consideration as you're deliberating through a prioritization process for what the overall impact will be to really a net add of Medicaid dental providers as opposed to net zero. And then finally, to circle in on Matt's commentary with the new finalized access rules, there is a comment on there indicating that access needs to be down to 15 days. And so that is a stark difference than what we currently hold ourselves to. So I would also like a follow-up on how that rule plays into the conversations that we're having here and now, likely at our August meeting, our next meeting that we have for the Oral Health Forum. Thank you.
Thank you. That's something we're definitely keeping in mind as we go through this process, and we're trying to hear from as many people as we can in the limited time we have to put together a directed payment, which has to be submitted by September.
Molly?
Yeah, thank you. I appreciate the presentation. This is all really good information to have, and I'm encouraged to see the progress that's been made so far. Just for clarification, I'm assuming that these directed payments are just for Medicaid members, not HOP, non-Medicaid, but can you confirm?
I believe the intention is that this is just for Medicaid members, and we are particularly going with this directed payment so that we get the federal match money.
Okay, that was my understanding, but just wanted to confirm that as well. And then just not with respect to the bundled payments, but with the previous slide, with some of the other initiatives that have been put forth. I think specifically the ones regarding new providers or incentivizing new providers. Has there been, when can we expect, or what, I guess, when can we expect more criteria potentially to understand what a new provider looks like? Would it be like a new primary, like a new PCD, a new clinic that is, accepting Medicaid altogether? Would it be a new provider to a clinic that's already accepting Medicaid? Would there be, if a provider had accepted Medicaid at one point and then stopped and then started, to see Medicaid again? I just think those are some of maybe that's already been considered, but I think as we get into the weeds of this, and if that is an initiative that moves forward, the more detail that we can have on that criteria would be helpful upfront.
Yeah, those are definitely issues we're working toward to operationalize it and also price it to determine what the cost would be, because those decisions all go into what the potential price would be and relative to the amount of money we have to potentially use for directed payment.
Matthew?
Yeah, just kind of following up on Molly, my understanding of the new final rule and the addendum to the Medicaid managed care rate setting guide would be, it makes it a really interesting comment that Molly made around bonus for new providers, because my read of the way they define state-directed payments and contextualize or clarified it means that a state-directed payment has to be directly tied to utilization and delivery of care to Medicaid recipients. So there may be a way to mechanize a bonus for new providers, but unless I'm remiss on my read, new provider just as a status wouldn't be sufficient. It would have to be somehow tied to utilization or delivery of care. So that was something I was going to mention there as well, and then ask you, John, when you said September, it's due for submission. Does it need to be submitted along with the 2025 proposed managed care rates for CCOs? Or is it submitted separately and evaluated separately?
It is submitted. The deadline, I believe, is September 31st for preprints.
Okay.
And that is to do, I believe, with the federal regulation around directed payments.
Okay. And part of the reason I ask is there was contemplated in the rules some interplay between traditional risk contracts and capitation rates set for, as well as how a state-directed payment set up and to what degree it has interface with a capitation payment. So that's part of my curiosity was, the interrelatability between traditional rate setting and state-directed payments, acknowledging separate review.
Laura?
Yes, thank you. I just kind of following up on what Molly mentioned, and I kind of had those same thoughts in my head, but I didn't want to verbalize them or vocalize them because I thought maybe it was my question was very simplistic, but I'm just going to ask it now. What about the credentialing for these providers? I mean, we're talking about non-OHP providers providing Medicaid services. Am I correct on that? I'm just trying to understand it.
Our assumption was they would have to become a network provider to qualify for this, that we're not
Right,
waiving.
so
the
they would
other-
need a DMAP number, they would need to be credentialed. I mean,
That's
that
my
takes
understanding.
time. Yeah, that takes a lot of time. Just wanted to, those are just kind of the couple things that are running through my head is those logistical things.
Dr. Manu?
Let's allow Heather to go first. She hasn't said anything, and then I'll respond after that.
Sure. Heather?
Thank you, Dr. Chaudhry. I I think that, we do have an issue with needing to bring in more Medicaid providers, to Matt's point, and just other considerations and potentially negative implications to offering some sort of directed payment to only new providers. I wonder if some work could be done around looking at supports to entice new providers that would be operated differently and funded differently. I don't know if I've mentioned this in this group, but possibly a grant program, and possibly technical assistance that providers totally new to Medicaid would probably benefit from. What kind of staffing do I need? What kind of administrative requirements are there? What kind of reimbursements am I looking at? How do I do this? How do I get prepared? How do I get DMAP numbers? All of those things. So I just, it's not a well thought out idea, but I do think there's something there that potentially could be looked at. But I think using a different pot of money and having a sort of a different level of support for that category.
I just want to add that it is very unlikely we'd pursue a bonus for new providers by itself. It would likely be something that would be in addition to one or more of the other options. Because we want to try to address the two issues of not enough providers and not enough utilization, are sort of the two big priorities we have. So it's very unlikely we'd pursue that by itself as a directed payment.
Dr. Manu?
I just want to verbalize what Matt has already instigated in the chat, in which Dr. Franzen had instigated earlier in the conversation. It's very critical that this is successful for everyone. All of us needs a bad word, but all of us are committed to bringing about the change that's required for our systems. And it is helpful if all of us are on the same page about it to achieve the best level of operational success. And so just to continue advocating what Matt shared, what Dr. Franzen shared, and also for myself as well, it would be great to have OFA return in August at the next OHF meeting.
I definitely believe we are scheduled to be at the August meeting to provide further updates on this, and we'll probably be in meetings with, if not this whole group, but individuals from this group to further talk about operationalizing some of these options. once you get a better idea of the potential cost.
That's very helpful to hear. Thank you so much for your advocacy and support.
I know we're coming up on the closing of this meeting. Are there any final questions for John? All right. Well, thank you, John and Mercer. We appreciate y'all for being here. I have reached out to Chelsea and OFLA to verify. I do agree with John that it is critical that they are here, but verify that they can come in August and hopefully September as well to the Oral Health Forum. Also, next month is a hybrid meeting. Anne has already reserved room 137D. And I will be sending that out, of course, with the agenda for next month. Also, the agenda setting meeting that is this Friday, it is going to be held via email, not virtually. So if you were planning on attending, please just shoot me a email to let me know that you would like to be included in it. And then it will just knock it out via email. Anything I'm missing, Dana, Laura?
No, thank you for the reminder about the agenda setting meeting. I forgot about that too. So yeah, send us your ideas via email and we'll do it that way.
And then I hope
Hey,
y'all
Janet.
have, yes.
Janet, this is Samantha right quick. Could you just send the agenda seating, the agenda setting email thread to everyone that's on the agenda setting invite list?
Oh, yes.
So that we're
Yeah,
all just included? Awesome.
Oh, yes, that's for sure. But just in case anybody else was just randomly planning on attending.
Got it. Okay, thank you.
You're welcome. Well, I hope you all have a wonderful 4th of July and safe travels, and stay cool. It's supposed to be 102 degrees out, y'all. So thank you for attending and have a great holiday.
Thank you, Janet.
Thank you.
Thank you. Bye, everyone.